Okay, now we're going to start chapter 68, and this week we're going to talk about neurotrauma. So basically that's going to be head, scalp injuries, and spinal cord injuries. Alright, so let's get started. The first thing I wanted to tell you guys about is head injuries and spinal cord injuries. The head injuries, you'll hear everybody talking about head injuries, but a head injury is really, the technical term is like an injury just to the scalp, not to the brain. So if there's like an injury to the brain, that's called a traumatic brain injury, but in the general public, people just call it a head injury. So for our purposes, we'll use those words interchangeably, but I'm going to talk a little bit about the difference between a head injury and scalp injuries and things like that. Head injury, the mechanism of injury matters, which is why when you're assessing your patient, it's important to find out what caused the trauma. Was it a car accident? Was it a sporting accident? Was it a fall? Things like that, because the mechanism of injury will give you a lot of information about what could be occurring inside the brain or not, just on the scalp. The clinical signs and symptoms are going to tell you a lot, and if you'll go back to our stroke lecture, the place in the head that has been traumatized, the symptoms will correlate with where in the head the person has been injured. The diagnostic testings, by that I'm talking about an x-ray when we're talking about spine, CAT scans and MRIs for traumatic brain injury. So I wanted to talk a lot about, or a little bit about concussions, because there's a huge movement now to prevent concussions. There's a lot of talk in the athletic circles about whether or not to even allow some sports that are higher risk for concussions, namely football, hockey, things that are lacrosse, the things that are high impact and can cause concussions. So there's 3 grades to concussions. Grades 1 and 2, there's no loss of consciousness. In a grade 1 concussion, the symptoms will last less than 15 minutes. So the patient might get hit in the head and be a little bit confused, dizzy, possibly disoriented, but then they come back within 15 minutes. In a grade 2, the symptoms can last beyond 15 minutes, where they're having prolonged headaches, confusion, disorientation, things like that. And in a grade 3 is any loss of consciousness, regardless of time. So if there's a loss of consciousness, that's a grade 3 concussion, and that's automatically considered a higher risk. So concussions, they don't really cause outward appearance of brain damage. And by outward appearance, I mean it doesn't show up on a CAT scan or an MRI necessarily. But the long-term effects of that, we're finding out, can be very significant. So people who have sustained concussions over and over, now we're seeing things like short-term memory loss earlier in life, Parkinson's syndrome, things like that. A great example of this is Muhammad Ali. If you see some pictures or video of Muhammad earlier on in his career versus towards the end of his career, where he was slurring his words, he had very bad Parkinson's, that was because of sustained concussions to his head over and over and over. The other thing that they're doing now is they, in middle schools and high schools now, they do concussion testing before the athletes start the sport, and what they're doing is getting a baseline, and so then if the athlete sustains what they suspect is a concussion, they repeat that test, and then they can tell how bad is that injury. And they'll do things like give you a series of things to remember, the date, the time, some simple math problems, things like that, and they'll get a baseline for that, and then if the athlete has sustained a concussion, they'll have them repeat that, and they'll compare those two things. However, middle school and high school athletes are getting very smart, so what is happening now is that they are sometimes throwing that first test, so they're deliberately getting some stuff wrong in that first test, So if they sustain a concussion, it won't show up because they'll still not do well on that test, and then they can get back out and play. So middle school and high school students don't necessarily make the best choices. They just want to play, and they're not really focused on the long-term ramifications of repeated sustained concussions. Beyond a concussion, this is what I was talking about with a head injury versus a brain injury. The scalp is very, very vascular, and the vessels do not tend to vasoconstrict very well. So when your patient gets a laceration to the head, there is a lot of profuse bleeding, but that doesn't necessarily mean that they've also had a brain injury. It could just be, you know, that this guy just maybe ran into something and sliced his head open. Does not necessarily mean that there's also brain damage. Same thing here. You don't know. This is why you need to find out, like, how did this happen? Did he, you know, just walk under a low-hanging tree and cut his head, or did he actually fall on some cement and scrape his head? Because now we might be looking at a brain injury. So that's what I mean by the difference. The scalp, this is a scalp laceration, but intracranial damage is when the bleeding actually occurs into the brain. That's going to show up on MRI and CT scans. Your closed head injuries are also known as your coup and contra coup injuries. The coup, C-O-U-P, it's not showing up very well, is the initial impact. So like, let's say this person is riding along in a car, and there's a car crash, and the patient's forehead goes forward and hits the windshield. That's the coup. Well, then because of the impact, it throws their head back like this, and then they get this shearing force in there, and now they also have injury in the back of the head. That's the contra coup. So they've got a coup injury, a contra coup injury, and then they can also have shearing because the brain kind of shears up against the skull like that. So you can also get some diffuse axonal injury because of that. And we're going to talk about that in a second. So your traumatic brain injuries can occur anywhere. This slide is really quite horrible. But you can have intracerebral bleeding, so bleeding like inside the brain. You can have epidural bleeding, and go back to the slide that we talked about a couple chapters ago. Bleeding above the dura, bleeding below the dura like this in a subdural hematoma. So, and they can occur in anywhere in the brain when that bleeding occurs. And that's the difference between an intracerebral bleed versus like a concussion, because in a concussion there's not going to be any visible bleeding like that. The other thing that you watch for in your patients who have had a head injury is this thing called battle sign. Your patients who sustain heavy trauma to their skull can have basilar skull fractures, where you can get fractures like in the bone here, pretty much anywhere in the head. But if you see this behind the ear, the bruising starts occurring behind the ears like this, that's called battle sign, and there's a high likelihood that there's also been a basilar skull fracture. Now, you have to confirm that on x-ray, but when you see this kind of bruising behind the ear, and oftentimes you'll also see blood and cerebral spinal fluid oozing from the ears or the nose, and that's going to be like a clear, just a clear drainage. And sometimes it's hard to decipher if it's blood or cerebral spinal fluid when they mix together, but if you get a white tissue and drop a piece of that fluid on there, it will separate out like an egg, and the cerebral spinal fluid will go out and around the blood, and that's how you know it's cerebral spinal fluid. It's called a halo effect. That's very dangerous because now you've got an opening into the cerebral spinal fluid that surrounds the brain and spinal cord, and your patient's now at high risk for meningitis. So you do have to be careful when you see this that there's not also a tear that could introduce bacteria leading to meningitis later on. This is just another example of a contra coup injury. You'll also hear it known as like the primary versus the secondary impact. So your primary impact, your patient gets hit by something, there's some kind of blunt force trauma to the head, that's the coup injury. but it forces that brain backwards, and now you've got more damage back here, obviously making the situation worse. The other thing that you're going to see in a contre-coup injury, like a shearing injury, is this thing called raccoon eyes, because especially if they hit the back of the head and the brain smashes forward, it can sometimes cause these raccoon eyes. Very scary if you see it in children, because children that are victims of shaken baby syndrome, child abuse situations, can get this because they get shaken baby, and that brain has that contre-coup injury. So if you're working peds or in the emergency department and you see this, it's suspicious. Especially once you start asking the family what happened, and if they don't give a good story or their stories are conflicting, probably need to talk to your manager and probably get police involved, because that's a scary situation. Okay, a contusion is one step worse than a concussion. So concussion is sort of like a diffuse, microscopic kind of injury, but a concussion is actually bleeding in the brain. So it's more like a bruise, or it'd be like a little hematoma there. So this is a worse scenario than a concussion. Diffuse axonal injury, I just was telling you about. So when you have a brain that's coup, contre-coup, and shearing, now all of a sudden you've got significant injury to that brain. This is a very dangerous situation to have. Patients who have diffuse axonal injuries almost nearly always lose consciousness. There's a high likelihood they're going to be in a coma for a while, and the outcome gets significantly less favorable when people have, just makes sense. The worse the injury, the more likely the outcome is going to be a little bit more devastating. And then followed by the intracranial hemorrhages, when there's actually bleeding inside the brain. So these are in order of severity. This is a better picture of what some of these intracranial hemorrhages look like. The epidural hematoma, this one is a little bit more scary, a more urgent situation. People tend to die more often from an epidural hematoma because, and depending on how bad this bleeding is, because it will push the brain in and there's nowhere for it to go. This one causes much death much more often than, for example, a subdural hematoma. You have a little bit more room because now it's underneath this dura, a little bit more room for that brain to push down, a little bit more favorable in a subdural hematoma. And then your intracerebral hematomas, these are more likely if you have like an aneurysm rupture or something like that. These intracerebral hematomas. Sometimes if you can get the patient to the hospital soon enough, you can take the patient to surgery and evacuate these hematomas. So you just put in a catheter and remove that if you're able to. It's not always possible depending on how bad and how quickly the bleeding is occurring. So how do we treat our patients who are coming into the hospital with head injuries? In all cases, what you want to do is keep that patient quiet. You want to do everything you can to not stimulate that brain. So you're going to keep the room dim. We're not going to have a million visitors in there. Probably have to put the patient on steroids to reduce the inflammation in the brain. You're going to want to keep the head in alignment, the head of bed up at 30 degrees. Keep them under good pain control because pain increases stimulation and it'll upset the patient. So you're going to want to give them good pain medication. Sometimes, if the swelling is too bad, the patient is seizing, the patient's intracranial pressure is too high, sometimes they will put the patient on a drug-induced coma where they're heavily sedating that patient in order to keep that intracranial pressure down. If they come in with a head injury, you assume that they have a cervical spinal cord injury until proven otherwise. So if you're out at the scene and somebody's in a car crash or something like that, you assume that that cervical spine has been broken. You keep that neck completely in alignment, because if a spinal cord is partially broken, and not completely broken. You want to make sure that the neck doesn't get twisted, because you could actually break the rest of that spine. So it's really important to keep that in alignment. I'm going to show you what that looks like in a minute. Mannitol is a great osmotic diuretic. We use that a lot in neuro patients when their intracranial pressure is getting high, there's inflammation on the brain, because the osmotic diuretic will pull fluid from inside those brain cells, put it in the vessels, and then the patient can urinate it out. Oftentimes they will put patients on a ventilator, and the reason is that way they can control their breathing. We tend to keep patients, their carbon dioxide levels a little bit low, because carbon dioxide molecules are bigger than oxygen, so if we can keep that lower, that's going to be less space taken up on those red blood cells. It's going to give us more space in the brain. And there is some talk now, and your book does talk about hyperventilation. There is some research that shows that hyperventilation doesn't work as well. And I'm not sure what the latest research is. I should have looked that up first. I'll figure it out before class. But hyperventilation is, especially if a patient's on a ventilator, you increase their respiratory rate with high oxygen levels, and what that does is it blows off CO2 and increases oxygen to reduce space in the brain because of the size of those two molecules. But some studies have said that it just rebounds back. So. But your book does talk about hyperventilation, so I did want you to know kind of what that was. This is what I was talking about with the cervical collar. I'm sure you guys have seen these. This is different than the neck brace that I showed you during Ortho Week. A neck brace is soft and it's used for neck strains. But a cervical collar like this is very tight and very rigid, and the patient can't move their neck at all. So you would put a patient in this until what we call C-spines are cleared, meaning you've taken them to x-ray and you can verify that there's no break in the cervical spine. If your patient does have a break in the cervical spine, they will often be placed in halo traction, and this is what halo traction looks like. And we talked about it a little bit during Ortho Week. These are drilled right into the head. This is all metal, and these are attached to metal bars that go down to a brace that sits on top of the shoulders and then wraps around the waist. And this will stay on for 8, 10, 12 weeks until those cervical spines are healed, because that spine, you don't want those cervical vertebrae moving, because if those vertebrae are broken and they move and a fragment of that can go into the spinal cord, now you're looking at a spinal cord injury. So you're trying to prevent that. Paraplegia is a spinal cord injury that leaves the person unable to move the lower half of their body. Tetraplegia is a spinal cord injury where the patient is unable to move or feel all 4 limbs. We also call that quadriplegia. So everybody used to call it quadriplegia, now it's called tetraplegia, so either one. Quad and tetra both mean 4, so there you go. Okay, so when we're talking more about a spinal cord injury, the most common population that this occurs in is young men between the ages of like 16 and 25, because they tend to be the big risk takers. And spinal cord injuries happen often with high risk behaviors. People diving into water that they don't know how deep it is head first is a big reason for that. Car accidents, motorcycle accidents are big. Snowmobile accidents, people falling out of things like trees and jumping off roofs, and things that young men tend to do. So the level of the injury matters, and I want you guys to know your book has a really good table on this, and I can't remember, I think it's table 68.3 in your book talks about what signs and symptoms you would see based on the level of the injury. Now, your book is, I think, a little bit inaccurate, because your book says somebody who has an injury at the level of C1 will need some help breathing and and is unable to move. They will be quadriplegic, tetraplegic. However, I have never seen anybody with a C1 injury survive, because that is extremely high. It's right under, right at the base of the brain, and typically if somebody is injured at C1, it wipes out the ability to breathe immediately. So unless you're standing right next to somebody, with an ambu bag or CPR or something, that person typically just cannot survive that. And then patients who have a C2 or C3 injury, I think your book is a little unclear about this, because the nerve that innervates the diaphragm comes out right between C3 and C4. So if the patient is fractured at C2 or C3, they will not be able to breathe on their own. And your book talks about they may or may not need mechanical ventilation. Well, if they're C3 or C2, they will be on a ventilator. They cannot breathe on their own. And that's how Christopher Reeves was, the actor that played Superman. He was in a horse accident. He was on a horse, and the horse jumped over a fence, and he went over the horse. Spinal cord injury, very high. He was, I think, a C3 injury, and he was on a ventilator for life. Patients who are at C4, they may not have to be on a ventilator. They will probably use their intercostal muscles to breathe, because the nerve that innervates the diaphragm to help them breathe it doesn't work great. And so those patients will be very prone to getting respiratory infections their whole life. They'll be prone to pneumonias, bronchitis, things like that. So those patients require a lot of nursing care with some good pulmonary support. The other thing that is so annoying, sorry. So the other thing I want you to know about is spinal shock and neurogenic shock. So your patients who have sustained a spinal cord injury, and I should point out here, there is complete injuries, incomplete injuries, and then there's kind of a variation in between there. You don't really have to know exactly, like your book will talk about Brown-Séquard syndrome. It talks about anterior cord syndrome, central cord syndrome. Just kind of look at that, but you don't need to know specifically like which one the person can feel on one side of their body, which one they can, feel on the other side. That stuff gets a little bit confusing, and those are a little bit more rare. But basically, the different parts of the cord that are damaged will lead to alterations in sensory and motor perception. So a complete injury, a person will not be able to feel anything or move anything. And that's going to be most of your spinal cord injury patients. But sometimes they have just a partial injury, and they can move a little bit and feel a little bit. So it really depends. But following a spinal cord injury, spinal shock and neurogenic shock are not the same thing. Neurogenic shock, we talked about last semester when we talked about the different kinds of shock. Neurogenic shock, it will occur after spinal shock has subsided. Spinal shock will show up early in the injury. This can show up, anywhere between like 1 and 7 days, like post-injury. And what happens is that there is a sudden depression of reflex activity below the level of the injury. So if a person is injured, at T6, below that they lose their reflexes, and that the problem with this is that the nerves that innervate the bowel and bladder are affected. So this is going to become a problem when we talk about autonomic dysreflexia. But that's spinal shock. It happens early on following the injury. After that, then neurogenic shock can develop. Neurogenic shock is the one then that leads to inadequate amounts of oxygen to the organs. And the reason that occurs is because the autonomic nervous system, especially the sympathetic nervous system, stops functioning below the level of the injury. So you get massive vasodilation, and the blood will kind of pool in the vessels, so you're not getting the oxygen where it needs to be, and that can lead to neurogenic shock. So look over some of that stuff. And autonomic dysreflexia, this is a major problem with your patients who have a spinal cord injury. Autonomic dysreflexia is a life-threatening emergency. It can occur throughout the spinal cord injured patient's life. But if they've had one episode of autonomic dysreflexia, you need to be careful because they can have a second course of, or a second round of autonomic dysreflexia. And basically what this is there is some kind of trigger. There is something causing the body to have this, what will happen is they have, above the level of the injury, they have severe hypertension, they will get a bounding headache, they will start getting diaphoretic, especially like in the forehead. They get congested, they get bradycardic. The reason this is a life-threatening emergency is because of the extremely high blood pressures. They can blow an aneurysm in their head, they can have a hypertensive bleed. So you've really got to get that blood pressure back under control. What you want to do is you want to sit the patient up, and then you've got to find out where the trigger is. And oftentimes, the leading cause of this is an over-distended bladder. So your patients who are unable to feel their bladder get a catheter in there, and because they probably have an over-distended bladder. If that's not it, do a quick fecal check. They may have a fecal mass in their rectum causing the rectum to stretch. That can lead to it. Severe pain. If there's like a decubitus ulcer that is starting to get infected, there's some kind of a trigger point. Some people that have this so severe, it could even be like wind blowing on them. Just the sensitivity of the wind can trigger this, and this will occur for any of your patients above the level of T6. So lesions below that, they're not at risk for having this, but and this won't occur until spinal shock has subsided. So, but again, that can be fairly early on. So make sure that you know what autonomic dysreflexia is, because you do have to fix it. You've got to find the trigger and you've got to fix it very quickly. So you want to prevent it, get your patient sitting up. Now the other thing with your spinal cord injured patients is that they will require a lifetime of good nursing care. And it again is going to depend on the level of the injury and the ability for that patient to move. So there's a lot of things in place now. Like this guy obviously has a fairly low spinal cord injury because he's obviously able to move a little bit. He's in rehab, and they've got him hooked up to belts and vests, trying to retrain him how to walk. This person over here is he's on a ventilator, so he's obviously at a C3, probably a C3 injury. So you can see he's attached to the ventilator, he's strapped into a wheelchair, and he has absolutely no movement of any of his limbs. So the problem here, because pretty much now the nurse has to be every system for this patient. So you're going to want to do good range of motion, because if you don't, you're going to have disuse syndrome, meaning the hands start atrophying and start kind of curling up. So good physical therapy, good range of motion several times a day, because you want to keep the patient healthy. Really good skin assessment. These patients are very, very prone to decubitus ulcers, which then can lead to infections, because they don't know to move. They can't feel when they're uncomfortable. So they just sit there all day, and if they don't have good caregivers, they are very prone to ulcers. They can get them on their elbows, they can get them on the back of their head, certainly on their buttocks, their heels. So skincare is important. Like we talked about earlier, respirations are very important. They're very